for the three of you, giving us setting the table for what's coming next. And so what's coming next is the next talk by Nick Ogden. Nick is a senior research scientist and director of Public Health Risk Science Division within the National Microbiology Laboratory of the Public Health Agency of Canada. He was trained as a veterinarian at the University of Liverpool and then did a doctorate in Lyme disease ecology at the University of Oxford. He currently leads the COVID-19 modeling and emerging science teams responding to the COVID-19 pandemic. The title of his talk is Predicting What Comes Next, Modeling the COVID-19 Epidemic. Nick?
Okay, thanks, Jack. Can you see that as a in presentation mode?
It's not in presentation mode.
Just hold on a moment. Let me. Is that?
It is now.
Okay, good. Okay, so thanks for the invitation to speak this afternoon. This is a slight update to the presentation that I've given before. I thought it was worthwhile to go back and have a look at what we did over the in terms of modelling over the pandemic and the epidemic in Canada. Really with a view to feeding the discussion afterwards on kind of what comes next, what are the lessons that we've learned from this, what has to be enhanced, and how we're going to move for the modelling to maintain as a support to the decisions on COVID long term as we move to an endemic state, endemic not necessarily meaning totally happy. And that we and also prepare for the application of modelling to other fields, other infectious diseases, which has not been useful to date, and also our preparation for the next pandemic or at least emerging infectious disease. So just as I'm not going to go through this as in too much of a technical way. I have many very talented technical people and modelers on my team, which I'm very grateful for their work. But I'll touch on these here and there on the main points of the slides. Of course, what we've been doing, what we've used the modelling for, is well, we've had relatively simplistic forecasting models, more complex dynamic models, which have been aimed to, for the most part, at least initially, to be looking at scenarios which help us to explore what might happen and what might happen if we implement different public health measures. And lastly, the use of dynamic models for long-term forecasting. So these have been used for strategic planning, how to use the public health measures, the situational awareness, and public health risk assessment and programs. The internal COVID-19 modelling group was set up in January 2020, mostly with, or initially entirely from people from my division in National Microbiology Lab. But then we expanded it to include epidemiologists and modelers from other parts of the agency. Shortly after, and thank you to the Fields Institute for setting up a meeting in February 2020, which was the nexus of the start of our external expert modelling group, which we have been super helpful to us throughout, and solid supporters throughout. Now continuing via the external modelling group, but also by the EID modelling networks supported by NSERC. And their role has been to validate the work we've been doing with a bit of model redundancy, enhancing our capacity and making sure that that our network of provincial and territorial partners have the modelling support that they need. And we've also been networked internationally via the WHO modelling group, and we've also, for at some point, been working with the Chief Science Advisors modelling group. I'm going to go through our 7-time kind of sequential modelling objectives from looking at what are the high-level impact of the impact and public health measures, informing on how to use public health measures, particularly in the context of lifting restrictive closures. Also, how to use those restrictive closures, early warning analysis and forecasting of the epidemic, impacts of vaccination, and then controlling the last 2 waves. So a number of models ranging from simplistic kind of models, analytical models, through compartment models, which have homogeneous mixing, but they have contact matrices, age stratified impacts, and the fragment master model, which is brought online for our forecasting purposes, and the most complex is the agent-based model. The initial modeling that we did was very simplistic, and this is, I think, probably the time at which modeling has had its, from my perspective at least, probably its biggest impact, which is the kind of jaw-dropping realization in February, March 2020, that just what an impact this infection could have on the Canadian population if we didn't do anything about it. And with these were, this is taken from a presentation that Dr. Tam gave in March 2020 as to what our potential options are. As we know, we did do something about it. Other countries decided not to, with some significantly different outcomes in terms of cases and deaths. Subsequent to that, then it's clear that restrictions are something that nobody wants, and we were tasked with trying to produce modelling which aimed to identify what sort of how other public health measures could take the place of those of the restrictive closures that stop people coming into contact with one another. And those public health measures are a limited toolbox. They're personal physical distancing, which is keeping apart, and maybe masking as well, which would ultimately reduce the probability of transmission when 2 people did contact. And then the enhancement of case detection and isolation and contact tracing and quarantine. And this entails being able to parameterize the models properly, which we did by virtue of having a daily review of the emerging literature by our knowledge synthesis team, and also of course by fitting the models to data for those context-specific variables. Then we would hypothetically lift public health restrictive closures in the future, and then see what happens with cases with different levels of public health measures. And this gives you an idea of the kind of outputs that the green bar. This is the first wave 2020 with the agent-based model, stochastic model with multiple model runs, with the median being shown by the black line. The green bar tells you when the restrictive measures are in place, and under when they were lifted at beginning of June in this model simulation that then there are a number of possibilities for the epidemic to trajectory in the future, which includes resurgence with the conditions in this simulation. And in the inset to the top, to the right, again bringing home the idea that if we let it go, we're still mostly naive and after the first wave and lockdown, and that if we didn't do something, then we'd end up once again with this huge epidemic. Again, with this very sobering context of modelling. So we did provide estimates via a number of modelling processes to what can you lift with certain levels of case detection and isolation, and also speed of case detection and contact tracing. But while modelling could provide those that kind of advice, this is one thing when we recognised certainly we were being hampered by a lack of data on what exactly are the effects of case detection and the effort of case detection and contact tracing. Recognising that the restrictive closures are going to be needed to maintain the epidemic, we looked at different scenarios for these, including enhanced case detection and contact tracing, physical distancing and combined effects, and also looking at what are the most risky venues to open. This is using the agent model approach, and which are those that are by consequence most effective to shut down if you have to shut down. And then how you should manage those shutdowns. And the upshot of that is that you need to shut down early to be effective, and you need to shut down long enough to bring the epidemic down to a level at which test and trace capacity can cope. And maintain control. So, and the upshot of this is that the earlier you shut down, the shorter you can shut down for. And similarly, if you do have a late shutdown, then shut down for rather longer than you would hope for to get those case numbers down. And again, that's better for both the health of the public and also health of the economy. We have throughout, I'm not going to go into details about this, probably worth a talk in its own right, is importation modelling, identifying right from the start of the epidemic right through to the present day, how many cases are expected to come from the global transit system through into Canadian points of entry, estimating the number of cases, the number of proportions of those that may be different variants, as we've learned more about that in recent months, and to be able to model effects of importation of cases as well as domestic transmission. As far as early warning analysis, we've had a number of approaches looking at, as many people have done, RT now, where we are right now as far as we can from surveillance data. Just this is an illustration of how modelling has come to the forefront of the general public's ideas that everybody knows about R. We have been very grateful of the support and help from our colleagues in academia throughout the process here. That we've had the looking at the short range future with a particle filtering approach of Nate Osgood, We've had our own internal short-range statistical forecasts. We've also been grateful for the support for Simon Fraser team, Carolyn Colin for long-range dynamic modelling forecasts, and also latterly with the collaboration with our colleagues at McMaster to develop a kind of joint PHAC McMaster model for that purpose. Or I guess once we started to have vaccines available, then a key question on our place before us was what kind of percentage of the population at what percentage of vaccination of the population can we then safely open up? Safely means without cases resurging to the point that they cause our healthcare system to crash. And the modelling team really rose to this really quite extraordinarily complicated modelling challenge, which is modelling the epidemic as it is, projected current, past, projected or unprojected vaccine rollout, the impact of vaccines on protection against transmission and against severe outcomes, and how that changes as you build immunity across doses, initially two doses, and now with the booster doses. And on top of that, simultaneously modeling the emergence of variants of concern. Initially, this was, of course, Alpha was the variant of concern. And from that, producing different scenarios of different vaccine effectiveness, which we didn't know about at the time, and we're learning as we went along different vaccine effectiveness, different coverage of the population, and then seeing whether it's safe in terms of healthcare capacity. And much of this you can find in the modelling reports that are available on our National Collaborating Centre for Infectious Diseases site. And from that complex, identifying when we can open up. And as we've learned, with one of the things that we put in as a caveat is the potential for more virulent and more transmissible variants to emerge, meaning that you have to have higher and higher and higher proportions of the population vaccinated in order to open up safely. And of course, that ended up, unfortunately, to be our reality. Then, just as we thought things were going well, we discovered that those levels of vaccination were not sufficient, as I mentioned, for variants, and particularly for Delta, more transmissible and more virulent. And with a slight bit of immune escape to add to the cocktail. And that meant that you have to have higher levels of vaccination. It's worthwhile just reflecting at this point on the waves, and although this is a model outcome rather than the actual real waves that we've seen, it serves as an illustration of the kind of the changing epidemic. We have had essentially, we are now on our fifth wave, and there are many people who suggested that this could maybe be a means for there's some kind of inherent thing epidemiologically behind these patterns. But with a bit more knowledge, it's clear that that's not the case. That the first wave was a wave because it started to emerge, and then we controlled it by lockdown. The wave 2 occurred because we eased public health measures and found out that we didn't actually have enough test and trace capacity and physical distancing in order to control it. Then we locked down again to control that, introduced restrictive closures in most jurisdictions. And when that was coming down, then we opened up again. But unfortunately, that was just at the time that Alpha variant was emerging. And then we had the Alpha wave, which was wave 3, which we controlled by lockdowns. And also coming into the summer months being controlled by vaccination as well. And then there was increasing loosening of public health measures just in time for Delta to appear and cause us problems. I think we were probably coping with Delta, but then, of course, not shown on here, we got wave 5, which was the Omicron wave, which is, of course, been the most challenging because of its high degree of vaccine escape. So we had modeled what could you do to control the Delta wave. And we've also looked at, well, one of the original hopes that we would be able to control it by getting enough people vaccinated. But unfortunately, the pace of vaccination at that time was not high enough. And the only way that you can control it, at least in model world, was by a combination of public health measures and increased vaccination. Of course, lately we've been challenged by the Omicron wave, which is more than anything we've seen before. Perhaps something that we expected to see, which is an immune escape variant that is less virulent, which has kind of been predicted as the kind of evolutionary trajectory for SARS-CoV-2 in a world with an increasing amount of immunity. But it probably occurred a little too soon for us. The number of cases is going to be very high. It's exceeded our testing capacity, as indicated by the surveillance data versus the forecasts here. And again, despite its reduced virulence, the speed of transmission, the fact that we've got still quite a high proportion of the population unvaccinated and also unprotected because of age and immune compromise and so on, that is challenging our healthcare system. We have looked at varying public health measures, but again, by and large, the impact is limited, including the impact of getting boosters out, because the Omicron emergence happened so fast and in advance of many of the public health measures and vaccination. So just some conclusions at this point from the work we're doing and have done is that modeling at the outset really did have an impact on our knowledge of what might happen, that spurred governments to control it and to continue to consider controls as being important. It has provided intelligence on the trajectory of the epidemic throughout, as Dr. Tam pointed out, and also on what non-pharmaceutical interventions, other than restrictive closures, could be used to control the epidemic, and if restrictions were necessary, how to use them. The modelling guided initial plans on how to lift restrictions as the vaccines rolled out. But that was kind of derailed by the rapid emergence of the more transmissible Delta variant before enough Canadians were vaccinated to prevent, when that prevented lifting of restrictions. And then on top of that, the rapid emergence of Omicron. I think it's worthwhile, I think we are looking at a cautiously optimistic future at the end of the Omicron wave, and maybe a little bit more of that in a moment. But just at this point, just to kind of feed the discussions to come, reflections I have on this are that much of the challenge that we have had has been down to data and the lack of availability of surveillance data. The fact that the surveillance system was kind of was a plane that was built mid-flight. That we have little information to really monitor and understand the effects and effort of public health measures other than restrictive closures. We have little information from hospitals and hospitalization, and there's certainly very little in the way of linkage of hospital data, hospital outcomes, and public health data, including vaccination status, and most recently with whole genome sequence data to really understand what's happening with variants of interest, variants of concern. And not only having all of those data available for modelers to use and to be linked, but also to have it in a timely fashion. That is a huge thing that has to be built for modeling to be more effective, at least in the context of a human-to-human transmissible disease like COVID-19. An important thing to do, apart from going on and looking at what happened with COVID, but is to reflect on the successes and build on them, and understand where things didn't go so well and learn from that, in order to start to embark on the relatively complex task of the long-term building of modeling for the decision-making in public health. How does that work? We have some example models of how public health organizations, government organizations work hand in hand with academic institutions, individual research groups. We're looking forward to the idea of the NSERC Emerging Infectious Disease Modeling Program will keep that alive in the future, although initially it is a short-term project in itself. But I'm encouraged by the engagement of everybody. I'm grateful for the engagement of everybody, and also the general widening of understanding that if we're going to do this meaningfully in the future, it's going to have to be a One Health project. In other words, we're not just looking at human infections, even if that might be our priority. We have to look what's happening in our environment and what's happening in livestock and wildlife nationally and globally. So despite all of that, we have heard some negative things about modeling, but by and large, I think modeling has come to the forefront in this pandemic as a tool to support decisions and help governments communicate the problem and potential solutions to the public. I think the modeling, COVID has been a very modelable pandemic or epidemic. I think the modeling has been exceedingly accurate, except under those circumstances when the modeling has projected scenarios which have not come to pass, by and large, because people in positions of responsibility have responded to those to those stark warnings by implementing control. I'll stop there, Jack, and let you move to Biella.